morning, everyone. Today I will present you the birth path established in Trentino for the assistance to women in pregnancy, childbirth, and postpartum. In fact, in recent years, in the province of Trento, a new maternity care model has been proposed and implemented. The birth path has allowed the majority of women, 7,500%, to be followed in pregnancy to the public services. Research data show that health promotion and continuity of care are the most effective action to preserve the women's health during pregnancy, childbirth, and postpartum. Women who receive the midwife-led continuity models are less likely to experience intervention and more likely to be satisfied with their care, with at least comparable adverse outcomes for women or their infants that women who receive other models of care. In Italy, the Superior Institute of Health recommends that women with straightforward pregnancy should be offered a model of care led by midwives with general practitioner, gynecologist, obstetrician, other medical specialists as consultants in the integrated multidisciplinary teams. Community are the main settings for clinical intercourse in a system integrated with hospital services. In the last 10 years, several national policies have been issued recommending the reorganization of maternal services, including closure of maternity units with less than 500 births a year, implementation of midwife-led models, highlighting the fundamental role of the midwife as lead carer and autonomous practitioner in care of healthy women for positive birth and public health outcomes. This is not a reality in all the region, and there are big differences between region, but in the province of Trento, several regional resolutions have been issued, some representing the translation at regional levels of national guidelines. Others originated at the same time from different dynamics. All of them contributed to setting the scene, offering political and legal support to the new path and local recognition to the role of midwives within new models of care. In fact, in this area, the national call for closure of units with less than 500 births a year led to the closure of 4 out of 7 maternity units, leaving several mountain communities suddenly underserved. We seized the opportunity to radically rethink the organization of our maternity services, reshaping it based on international scientific evidence related to appropriateness and effectiveness of care, financial sustainability, safety, equity, and accessibility. The NatCare project of 230 enabled us to learn from international experiences of midwifery, continuity of care implementation in sparsely populated or mountainous area in other countries. In this way, in 250, the maternity pathway will be introduced to the women living in 3 areas and progressively extended to every territory of the Trento province. We moved from hospital doctor-centered care to community-centered care, considering women's journey and birth pathway as a continuum. We moved our patient clinics to the closest facilities to women's houses to get closer to them and their network of a relationship in the awareness of birth as a biopsychosocial event. Midwives went back to their community in terms of both local territory and net of people as main carriers in a case loading models. This was the beginning of the dedicated midwife-built birth pathway. The key features of this new pathway was the continuity of care and the carer, so a named midwife who followed the women from the beginning of pregnancy to the postpartum, until the postpartum. Caseload midwife as case manager, a strong collaboration between different professionals, so multidisciplinary team, a structured path, and real empowerment of women, and integration between hospital and community, and shared documentation. Maternity care pathway agreed for all women depending on the risk assessment at booking appointment by the midwife. The name midwife will provide continuity of care and it's the midwife who involved other professionals depending on the risk assessment. Here you can see the circle of the birth pathway with the first encounter at the beginning of pregnancy with a direct access or book appointment. In that occasion, the midwife did an assessment and organized an individualized care. And then the dedicated midwife follows the woman throughout their journey, whatever risk status. In case of risk factors or pathologies, she involves the specific specialist in teamwork. Every 40 days, she will encounter the woman. And also after birth, within the first week after birth, there will be a postnatal visit at home, and at end of the pathway at 40-60 days after birth, last home visit from dedicated midwife. And here you can see the path in pregnancy and during the postpartum, with the continuum of care also after discharge. And the teamwork is the strength of the community services, and the key in this teamwork involved gynecologists and obstetric specialists, midwives, psychologists, other professionals, social workers, service leader, and manager. The put in place implementing this space hasn't always been so easy. Therefore, we have to put in place several strategies which involve not only women and their families, but also stakeholders as regional governor and local politicians, professional bodies, national and local college of midwives, trust leaders and managers, and the services for emergency and mountain and rural community. To translate everything into policies, we organized meetings with women and their families, and it was pivotal, the petition from citizens to regional and local governors and to trust direction. And then we organized a continuum of education, training of midwives, and we do a strengthening of collaboration and created a new shared culture. And was really another some key factors was the support of administrative staff involved in the NAT Care project, and the changes in the political context. There are the stakeholders involved. There were some facilitators and some barriers, both internal and external. The implementation, a strength of this path is to be a real alternative to traditional standards of care for normal pregnancy, and also the accessibility and the continuity of care provided to women, and also the reinforcement of midwifery profession. Otherwise, barriers could be problems related to reorganization of obstetric services in the region, acceptance of new services by service user, professional and other stakeholders, and also lack of similar experience and models in Italy. For translating evidence into policies, we raising, promoting, supporting understanding and awareness of users via public events, and taking all existing opportunities to share evidence in support of the path and its salutogenic approach to care. We organize the multidisciplinary team meetings, evaluation, auditing, and monitoring of actual care, planning action for implementation of existing services. Strengthening collaboration and integration between hospital and community setting. And another goal was the continuous training, lifelong learning project to promote and support the right culture, knowledge, skills, and competencies of health workers. Prior to the start of the birth pathway, most women were followed by a private gynecologist, while today 7,500% of women in the province of Trento are under the care of the public services. Women appear satisfied with the intake, most of them having a dedicated midwife who perform most of the checks. More than 100% of women would recommend the service or midwife to friends and relatives. These are data from 2020, so last year. Here you can see our key to success, the ability of seizing the moment, turning potential obstacles and challenges into opportunities, the power, strength of women's and local community voices, that was the real protagonist, the specific midwifery leadership style, and the continuous support from evidence in literature and other midwife-led models internationally and nationally, and from data and evaluation of outcomes of the new case loading path ostetrica dedicata. Otherwise, unsuccess can be linked to the dearth of support, interprofessional power dynamics, lack of understanding of the need for maintaining the core features and standard of the path, loss of the vision in case of organizational changes, disconnection from women and families' voices. This is so. Thank you everyone for the attention, and here you can find some link to video to learn more about our birth pathway.